Hi everyone. For those that do not know me, my name is 𝗧𝗜𝗘𝗦𝗦𝗧𝗜𝗠𝗘𝗦𝗦. I am a licensed psychotherapist with a specialization in Lyme disease, and I'm so excited to be back for my third live stream. I also want to say thank you for your amazing questions we ever have, so please keep them coming. We probably won't be able to get to all of them today, but if we don't, definitely the next live streams next month, look out for those questions to be answered. Before we get started, I'm going to introduce Dr. Jemsek, and then we'll get to the questions.
Good afternoon, everyone, and thank you for watching. And we Jules and I and the others that I've worked with, your attention. We're trying to keep our program as educational as possible and informational as possible, because this goes without saying, there's a lot of chaos in our world. There's been chaos in the Lyme world for 25 years or longer, and so I'm going to try to bring some sensibility and order to the process. And as part of that, last month Candy Willett and I did a program, the first ever discussion of observations in pediatric pre- and post-adolescent or pre-pubertal and post-pubertal individuals. We stratified it, and we, over the years, have made observations about what signs and symptoms may occur in these children that may portend eventual development of Lyme borreliosis, or in fact express itself at an early age as Lyme borreliosis. And so that was done in January. It's an hour live stream, and we followed that up with a video that's now posted on YouTube and Facebook, about 20 minutes to sort of go through that once more and cement some of the teaching points. And today or tomorrow, I'll go ahead and post our outline on a one-page document that talks about this, so you have it. It should be trademarked, but it's not, so it's my gift to you and sharing information. It's not perfect, and some of it may be incorrect, imperfect, and there's certainly other things that we'll be adding to that over time. But it's a good start. It's based on, I don't know, 15 plus years of observation. So I hope you benefit from that, especially the parents wondering what their child was having this, that, or the other symptom that's confounding their life and their development. And again, as Jules has said, the questions were just the best ever this time. We do our best to answer many of them. We're not going to do any roadblocks today. If you remember, I haven't posted the roadblocks yet. We have about 25. I think we've discussed 6 or 7, and just don't have time today. We want to answer your questions, and that's going to take the whole hour, I believe. Thank you.
All right, we're going to start with one of my favorite questions we got, which is, what are the ways people can get Lyme disease?
So this is a good question. So, why does one person in the family get devastating illness with multisystemic issues and neurologic issues, neuropsych issues, and the sibling is okay, but a lot of times there's the families where multiple individuals are affected. So if you go back to our basics, it has to do with genetics. So every sibling doesn't have the same genetic pattern. They have genes, of course, but not the same identical pattern, unless we're talking about and then there are different lifestyle issues that come into place, different stressors. And I look at Lyme really as a mechanistic disease, so that we have already incorporated many of the pathogens that we end up treating. In that way, it's a little bit like HIV/AIDS. So I think a lot of the exception would be babesiosis. So that would be a game changer if an individual developed Babesia and the sibling didn't, for example. I think going on to another point, this is controversial, but I just told you we have family members or families. I think vertical spread, asymptomatic vertical spread of borreliosis, the Borrelia spirochete, is grossly underrated. It's been studied. Nobody wants to think about it or look at it, quite honestly. But this spirochete can do what it wants and go anywhere, invade virtually any tissue, and survive the immune system in the fetus, in the mother, and so forth. So I think that is also get an exaggerated infection load when you're sexually active, and I think that's also extraordinarily common. I call it guilt-free STD, and that may be a triggering point for one of the sexual partners. And of course, tick bites. And I think a way to think about this is there may be other vectors, and there probably aren't, but the deer tick, ixodes, it's more efficient. I think that's the way to think about it. So horseflies, mosquitoes, maybe not very efficient, but the ixodes tick is, here and in Europe, that's cousin. Ixodes is just the most efficient.
The next question is, what causes seizure-like episodes in Lyme patients, and why don't they show up on EEGs?
That's a great question. So I'm talking to 1,000 neurologists right now, especially those who perform electroencephalograms. So the seizures are happening in a non-cortical area. So we have gray matter, we have white matter. So borreliosis is white matter, the subcortical area. It affects the cortex, of course. It affects the spinal cord, peripheral nerve. It can affect anything. But it really likes the limbic system. It really likes the brainstem and upper cervical roots. And if you get off irritability and destabilization, you start having seizures. Well, these seizures are atypical. They go by a variety of names, and because Lyme borreliosis and neuroborreliosis are so prevalent, and because seizure activity or seizure equivalents are prevalent, and because they're not following the traditional pathway or the traditional presentation in mainstream medicine, they get discounted as hysteria and so forth. So the things that we use are subcortical seizures or paroxysmal discharge, or atypical seizures, or non-epileptiform seizures. But the worst name of all is, and this is what's like probably more than any other name, is pseudoseizure. Mm-hmm. Pseudoseizure.
We don't like that word.
We don't like that word. Pseudoseizure. It's not the traditional cortical seizure, so in that sense, it's a pseudoseizure, I suppose. 90% of the people that hear that someone has a pseudoseizure say it's a fake seizure. And I can tell you, patients over the years have been discounted and ridiculed as having, quote, fake seizures. And I continue to find seizures, especially repetitively, and to be ignored. You can go to an EEG monitoring lab, and I'll be pointing out, and come away with no activity or blip here and there, a little spike. Here's the deal. Bottom line, EEG measure the cortex, the gray matter. They do not look at the white matter, the limbic system, and that's where the seizures occur. So I've seen this maybe 1,000 times, and it's very frustrating, but these are real seizures. Again, I think they're the most common seizure on the planet because of the prevalence of Lyme borreliosis and
I feel completely depressed on other days. I feel that is normal. And that doesn't have to be just feeling depressed. It could be having a horrible headache one day or any other physical symptoms. And then the next day or the next week they feel fine. So yeah, that is very, very normal. And me and Dr. Day were talking about this last night. We were saying we don't necessarily think there's anything different physiologically going on, but the amount of toxins in the body at any given time can change drastically, can change for a number of reasons. So sleep, for instance, how much sleep are you getting? Did one night or 1 week you get absolutely no sleep? That's certainly going to affect the amount of toxins in your body, which is going to make you not feel very good. Diet, how are you eating? Did you have a really bad meal that, had a lot of gluten or dairy or sugar? certainly that can increase the amount of toxins in your body. Stress, work-life balance, relationships, even stress of an illness like a cold or the flu certainly can cause an abundance of extra toxins. And also you are in your treatment. So if you're on a very heavy week of antibiotics, very natural that you're going to feel, really, really bad compared to maybe last week when you weren't on antibiotics. So again, I think the question is yes, it's very common that one day or 1 week you can feel good or have a good day, and then the next day you can feel like crap. What do you think?
Yeah, I think the ebb and flow day to day is toxin related, but it's not like we, lose another billion brain cells in a week. It's you've got a very emotionally labile immune set, which is not controlling much of anything. Angry set of stealth pathogens invading the central nervous system, peripheral nervous system, and many, many other cells in the body, causing you to be immunocompromised. And so you're in a very susceptible state. And so if the toxin flow is high, as Jules said, you're having a bad day. And if it's lower, you may do a little bit better.
All right, next question for Dr. J is, we actually got, copy on here, it's okay. Okay. We got a lot of questions that had to do with, will these symptoms ever go away, or once treatment is finished, or you're ending treatment, will they still be present? So some of the common ones we got were, will headaches go away? Will noise sensitivity go away? Neurological damage like numbness or tingling in hands and feet, and mental health struggles like anxiety and depression.
So it's all lumped into one, but it basically boils down to thoughtful methodical eradication of the pathogens which are destroying the neural channels and other tissues, of course, and with the goal of having a good balance between treatment and being off treatment, prefacing all of this with stabilization. So our patients learn how to detox, they take a modicum of supplements, we make adjustments for their sleep if necessary, and we control the pain to an acceptable degree and the psychiatric status and so forth. I just want to say one thing that may help, because I know that many of you listening have had treatment outside our clinic, and that's fine, but I'm just, the Lyme world's in chaos, and the Lyme treatment world is also in chaos. So literally, if you go to 100 different, quote, Lyme treating physicians, or who say they are, at least, you're going to get 100 different approaches. So when you say, well, I haven't gotten better, I've been treated, well, the approaches are different, and they haven't been standardized in a way that makes sense. There hasn't been an educative process, a learning process, a certification process that says you're able to treat this complex illness. A lot of the people that are treating are calming the symptoms down and helping, but most folks out there don't know how to work with biofilm properly, and they certainly don't know how to treat babesiosis, which I think is the driver. And so if headaches go, earlier on a live stream I talked about the different kinds of headaches. It depends on the headache, of course. And some of the peripheral nerve stuff, there's going to be permanent damage, which is going to be, which may require a little bit of medication. And but yes, there will be healing. But guess what? It's going to be slow. And as far as mood goes, I have frequently seen patients who are more depressed at the end of therapy than at the beginning, where they're thinking better, they're more active and more energy. And it's all about that particular part of the brain in the subcortical area, where the mood is generated, is just trying to recover. So the infections are gone, but there's damage done. And that's a question a lot of people ask. Am I actively sick, or is this all damage done? That's a great question. There is damage done. A lot of time you'll need certainly herbal support, lifestyle support, and some pharmaceutical support until such time you can heal. And the healing process takes months, maybe up to a couple of years, if not a bit longer. But during that time, you're mostly feeling much, much better. So it's not all bad.
I've seen some of your comments that our internet is being pretty funny and really choppy, and I'm so sorry for the people who've had to sign off because of that. I'm hoping that the internet problems resolve in a few minutes, so bear with us. We're gonna keep going. Hopefully it will change. But the next question is, what is the average length of treatment, and what does being in remission mean?
So I can only speak for our clinic, but I would say 85% of our folks, whether they're oral or IV, can get optimal therapy in a period of 12 to 15 months. And this is treatment every 8 to 10 days with careful monitoring of blood counts and, of course, off time. One way to think of it, and I don't want anybody that's had cancer to think this is an insulting, but this is a bad disease. This ruins lives. It destroys childhoods. It destroys families, and is magnified by the ignorance in the general population and the general medical population especially. So treatment, we do pulse therapy, and I would say our average days of treatment in a month is 8 or 10. We give downtime and for recovery. So it's a lot like chemotherapy in that, any of you know anything about chemotherapy, the oncologist doesn't come in and say, Mrs. Jones, you've got a horrible solid tumor, and but we can treat it. We got about 10 drugs here, and we'd really like to get this over as quickly as possible. So we're going to give you 10 drugs for 30 days, and then you should be good. Well, Mrs. Jones will be a puddle on the floor. The body has to rid itself of its toxins and waste as cells are dying, and along with the spirochete and other pathogens. We have to find a balance. Because for the immune system to recover, we have to have, we can't have excess toxicity. So it has to be a balanced approach. Plus, all our targets in cancer and our pharmacology in LBC treatment are dealing with slow-growing organisms. In cancer, your cells are slowly dividing, being killed off in a sequential way in an intelligent progression, and with a purpose and priorities. So we can't rush the process, not only because there's so much toxin produced and that needs to be balanced, but also our targets are all slow living. Bartonella, Babesia, certainly the spirochete, and they can hide and go dormant and live in biofilm and so forth and so on. So it is a process, and we do sequencing. We don't do the same drug all the way through, although we're constantly attacking the life forms of the spirochete. We put a lot of emphasis on treating babesiosis early on, and in recent months we're retreating babesiosis when we have an immune system a little more intact, so that we can reassure that babesia doesn't cause a recrudescence. And if you've watched any other live streams, I put babesia number 1 as the number 1 cause for people relapsing or stalling out.
All right, the next question, also an amazing question, and this is a question I get so commonly, so thank you for those who have submitted this one. Treatment can be so extremely hard on me emotionally and mentally. At what point is enough enough? Or at what point do I decide I need to take a break from treating in order to take care of my mental health? So we take mental health, we take mood very, very seriously. We don't believe healing can be done if treatment is just completely intolerable and you're miserable. Especially if there's any suicidality or thoughts of self-harm, we immediately say, okay, it's time to take a break, whether that's a break for a few weeks, a few months. Another reason why Dr. Jemsek does the pulsing therapy, which I know he's going to get into in a later question, but that helps give the body a break if you're doing, for instance, a treatment protocol, 2 weeks on, 2 weeks off, or 1 week on, 3 weeks off. It gives your body a chance to rest. But even that can still be sometimes too hard for people. So if we feel like you're ever at a point where, you're just completely overwhelmed, you're feeling so depressed, you're losing hope, feeling suicidal, we say, okay, it's time to take a break. And the poems that Dr. Jemsek always refers to, the POEMS, P being the pain, O being the other, such as social support, E being the, metabolic care, the endocrine system, M being mood. So again, we have to take care of the mood in order to fully treat and heal. So the answer to that is yes, we definitely encourage taking a break if you feel like you're at your breaking point and your body has just had, enough. Do you have anything to add?
That's great. S is for sleep.
Oh, I forgot sleep. Yep. Poems, not poem. Thank you.
That's great. I've never had anybody quote my poems.
I love it.
Like that, and that's that's good. That's wonderful. You did a great job. Okay, well, you had another question, I think.
Okay, so yes, the next question for Dr. J is there a correlation between deteriorating discs and Lyme disease? In 2005, after a car accident, a deteriorating disc had to be replaced. Now I just had 2 more discs replaced in my neck and another being monitored. Is this an anomaly, or could my years of fighting Lyme disease have caused early damage to cervical discs?
It's a great question, and I think the answer will help a lot of people who are confounded by unexplained degeneration of their spine, usually, or other joints, where there's no history of trauma or immobilization or anything like that. I go back to my day in HIV/AIDS when I was doing research with a DEXA machine measuring bone density. And of course, a lot of my subjects were in their young 20s, mostly male, and we were finding in these 21, 22, 25-year-old males that they had osteoporosis. They'd been sick for a few years, and the common denominator here is chronic inflammation. And oh my God, if there's a disease that causes 24/7 spewing of inflammation without a break, Lyme borreliosis is, because it goes on and on. If you have terminal AIDS, you're chronically inflamed, you're going to, in the old days, you would die. If you have terminal cancer, you have chronic inflammation, you're going to die. If you have lupus, you have a similar situation if you don't have intervention. But with Lyme borreliosis, there's nothing compared to it because the spirochete is so evocative in terms of creating inflammation, and we've shown that on previous lectures. So yes, the answer is we see accelerated degeneration of all the support structures, ligaments, tendons, cartilage degeneration, creation of osteophytes, arthritis throughout the spine. And so just to give you another example, if I had, we've seen this numerous times, our patient has been ill for 3 to 13 or 23 years, will, for whatever reason, get a spine x-ray usually by an outside physician or something we're interested in. So let's say we have a 35-year-old. Oh my God, the spine films look like they're 70 years old. We've seen that time and time again. So what do we have here? We have accelerated degeneration that's visible by plain radiography. And can you imagine what's happening to the rest of the body? But yes, so we see the inordinate amount of diffuse spine degeneration, which is unexplained. I mean, these people aren't paratroopers. They didn't fall off the roof. They hadn't had a car accident, and so forth. Another conundrum that happens quite often is with all this degeneration, people have cervicogenic pain because they have neurogenic pain. Now, what if they get a mechanical problem with the foraminal opening and, the compression, the sort of thing that somebody would get a laminectomy for or do a spine fusion for? So, we have constantly seen folks going to the orthopedic surgeon, neurosurgeon for lumbar surgery, neck surgery. And the threshold for pain is much lower if the nerve is inflamed. It's kind of like having a big open ulcer on one arm and nothing on the other arm, and putting salt on one arm or both arms. Which one's going to hurt? So the threshold for firing off, having painful neuropathic issues or painful local issues, spasm, and so forth, is much lower in our patient population.
Our next question is, could this disease hijack my daughter's personality? Yes, I absolutely think it can change people's personalities. A lot of times my patients often tell me that it's the worst part of their Lyme disease or this chronic illness is not what it does to their body, but what it does to their brain and what it does to their self-image and how they feel about themselves. Obviously Lyme can cause irritability, sadness, depression, anxiety. One of the biggest changes in personalities I see is what we call Lyme rage, or, this unprovoked anger, which is different than healthy anger. Healthy anger usually has a cause and a potential solution. A lot of times with, again, quote unquote, Lyme rage, it's unprovoked. There's really no reason. And so I often hear people lashing out at their loved ones, inconsolable crying fits, punching walls, fantasizing about violent acts, which, they're not a violent person. And there's a lot of self-loathing with that, and shame and guilt, because that's not who they are. It's what this illness is doing, to their brain and the inflammation it can cause. So the Lyme rage is huge. And then you can get to the more serious stuff like depersonalization, derealization, which basically is a detachment of the world, or, being an observer of yourself. People say they almost feel like they're living in a dreamland, or the world's not real, or even, their body isn't real, or they see distortions, and it's very, very scary. So absolutely, this illness can have devastating effects on the personality, how people feel about themselves. But I do want to reassure that it's not who this person is. It's a result of this illness, and a lot of these things get better with treatment. So stay hopeful, and things do get better. Do you have anything to add on that, or should we go to the next one?
So let me just say that, again, another excellent summary, but the anger and the mood changes come from the lower brain, and that brain don't think. So it overwhelms our prefrontal cortex, which, let's say we got inappropriately angry about something, just angry, but the prefrontal cortex would say, oh, okay, cool, there's a reason for that, let's just go another route. The amygdala, which is the double gland, for anger, fear, anxiety, panic, is just a little hot coal down there, and it's firing off and overwhelming the prefrontal cortex. And I think on the last session I did with Candace, I talked about my 4 stories of psychiatric degeneration, starting with irritability as the ground floor, and then working up to the top floor where we have psychoses, depersonalization, and so forth. So everyone with this illness is irritable. That's a given. That's the first floor. And
everyone.
Everyone. And so they all have that. I'll get on with the next question, which is how do you control nerve pain? Bearing in mind there are many types of pain. We think there are 3 types of pain. Nociceptive pain, which is mediated through A fibers, which are large fibers. B fibers are mainly internucleal fibers in the spinal cord. C fibers, however, are extremely important as pain receptors for small fiber issues, and they represent a different type of pain, which is burning, stinging, radicular, whereas the A fiber is more for musculoskeletal. So what we see is an inordinate amount of C fiber pain, which we call neuropathic pain, or mononeuritis multiplex. Why do we call it mononeuritis multiplex? Well, we lifted the name from diabetes because in advanced uncontrolled diabetes, there's nerve damage everywhere, but it's much more common in Lyme, much, much more common. And so we talked about controlling this. First of all, given that there are different types of pain, the nociceptive, which is A fiber, the C fiber pain, neuropathic, and then we have regional pain or central pain, which we've talked about in the past, which is the worst. That's when the wind blows, you hurt. You can't put your clothes on, it hurts. Can't be touched. Don't touch me. Many of our patients have all 3, and they require different approaches, none of which include narcotics. We are anti-narcotic. They don't help. We do everything we can to reduce toxicity. We use lots of magnesium in addition. But what we've done, I guess, for so many years is, back in the day, I said, why not just use the neurotropics and see if they synergize? And I guess that comes from my HIV days, where we finally got into combination therapy. And it works. So we have a handful of neurotropic agents, some of which block calcium channel discharge, and some of which block sodium discharge. And when they work together, they can control neuropathic pain quite nicely. We're also in the last 2 or 3 years using neurotropic creams, which are compounded and have several compounds, including ketamine. And we apply those to trigger areas or toothaches, which are common in the head and neck area. And anybody that is my patient and knows that when I examine you, I'm tapping your preauricular area, I'm feeling your neck pressing, and I'm feeling your carotid bulb, and then I'm going up and down your spine to look for what I call toothaches. And a lot of folks are pretty stoic, but if I press hard enough, I can see them jump, and I say, did that hurt? And I said, no. I say, why'd you jump? So a lot of people suffer in silence. I get that. But it's very common. And is it wrong to mask the pain? No, it's not wrong. We need our immune restoration or recovery. And if you're in pain, that's a block. That's a roadblock to recovery. So combination neurotropics, I'll give you a couple examples, and I'm not recommending anything. And a lot of people can't tolerate some of these, that's fine. So we try to find a combination that works. So we use gabapentin, pregabalin, or Lyrica, carbazepine, which is trileptal. We use lamotrigine, Lamictal. We can use Zonegran, which is onisimide, or we can use Tegretol. And we use those in combination, and there are a couple of other things that we look at and use in combination. It usually works pretty effective. So we titrate up to the lowest effective dose. It's always the lowest effective dose. And we go from there. I think the next question has to do with muscle convulsions and contractions. So we need to distinguish between body jerks and dystonia, which is, fixed contraction, which is the worst form of that. Clonus, and that comes from the limbic discharge. That's an inappropriate, unchecked, unbalanced firing by the limbic system, or the basal ganglion, through the basal ganglion predominantly, which modulates muscle contraction. The other form, which is not painful but disconcerting, is fasciculations, which are worm-like movements, very fine fibers twitching. It's not a tremor. Tremors, by the way, also come from the basal ganglion. So it's a very fine fasciculation. That's a lower motor neuron phenomenon. Okay, where the roots come off the spinal cord, that's a lower motor neuron phenomenon. So we distinguish between those, and they may have similar approaches, or they may not have similar approaches. But you can control them with the neurotropic program I gave you. Again, we can use neurotropic cream if we know what root is firing off inappropriately. I would say the majority of our folks have trapezius tightness, like crunchy trapezius. So now you got myofascial pain, which is another pain. So that's A-fiber pain, okay? But the nerve fires off, the muscle gets fatigued, starts to break down, and hypertrophy, and it's sore as well. So that's a different approach, but we see that all the time. So when we examine patients, a lot of them have Mike Tyson traps from firing off for years. And say ouch, and then you can feel the crunch. I mean, it's just like what a chiropractor would do, I suppose. Thank you.
All right, next question is, this illness can be so isolating. How can I get the proper support? I know a lot of providers, especially the providers here, won't even treat unless you have a support person or a support system in place, because we're firm believers in you won't heal unless you have the support that you need. So biggest support systems, family. I know this is tricky because sometimes a lot of family maybe doesn't believe in this illness. I hear that all the time. So getting your family into the appointments with you, getting them on board with this treatment, having your providers explain to your family what the heck is going on, though this is not all in your head, this is a real illness. That's my biggest advice on how to get support from your family. If you have family relationships that are toxic, you can distance yourself from them, find other family members that are truly supportive. It really makes all the difference in the world. And then having friends, having social support. So again, this can be really tricky because a lot of friends won't be able to relate to you or understand you in the way that you really need to be understood. So my biggest advice would be to find, an online support group. I know there's tons of support groups on Facebook. I know I run an online support group. I can give you guys information later on that. If you want to contact me individually, I can link you up with different support groups that I know exist around the country. Finding a therapist who is Lyme literate. But any therapist at all is great. It will really help if you're working with someone who understands this illness. And also finding the right providers, finding a doctor that is truly Lyme literate is extremely important in getting the support and the access to the treatment that you need. And again, I know I mentioned detaching from toxic relationships, but I think one of the biggest setbacks and roadblocks I see with patients is their support system not understanding, not being on board with this treatment. And it's hard enough. You don't need to be alienated from people in your life. You just need to be surrounded by people who are on board with treatment. So that's my advice for how to get support: family, friends, finding connections online through support groups, finding a good therapist, finding a Lyme literate medical doctor, detaching from toxic relationships.
Thank you, Jules. Yeah, we won't treat patients who don't have support because it's going to fail. If you don't have support, find support. Anybody at the church, in a social club. Do you have a family member that you can get closer to? Do you have a neighbor that you can get closer to? So important, because this is a complex illness, requires complex therapy. It requires rather lengthy therapy, but it's months, not years. So for those of you who've been treated for years, you haven't had good treatment, more or less. That's not to say we don't have folks that have been ongoing for years, but it's like a minor percent of our population. We'll treat a patient for a year, 15 months, follow them 6 months, a year for a couple of years, and then they're discharged unless they want to come back. And that's a good outcome. There was a question, I think, coming up about treatment fatigue and when do you stop and is it okay to take a break. This goes back to the balance and the pulsing, and by pulsing I mean not only weekly breaks, but breaks that include weeks, either 1 or 2 weeks, sometimes 3. Now remember, you've got a situation where you've learned, or we've managed how to stabilize you, we've managed to stabilize you, and you've just become too toxic. So we see different patterns, and it's all about patterns, really, quite honestly. And the patterns are very important for us to recognize and understand, and we do. So when we see patients getting too toxic, uber toxic, that really doesn't help the cause, and they need a break, or we need to shorten therapy, sometimes from, say, 2 weeks to 1 week, and then take a break of a week or 2 or longer. And yeah, I think breaks need to be built in because, again, the spirochete is several times more evocative to the immune system when it breaks down because it has an outer protein surface, lipoprotein, not polysaccharide. Lipoprotein tends to be much more provocative. That's what spirochetes have. That's why we have a ◧�𝗏𝗏. That's why the ◧��𝗏 was described by Jerisch and ◧��𝗏, who were dermatologists in Middle Europe, Denmark and Germany or whatever, they're cousins, and they were treating syphilis patients with bismuth, antimony, what have you, and they were seeing huge lesions pop up, fever, chills, sweats for a day or 2, and then the lesions would involute and go away. And that's where the name, and they saw it so many times with their syphilis patients and secondary Louis, they called it a ◧�𝗏𝗏. And so what was happening? Syphilis is a spirochete, right? It has the same lipoprotein surface. And guess what? We got millions of spirochetes in the brain and all its life forms. So if we don't stabilize you before you get into therapy, it's not going to work. If people aren't around you that know that you're overwhelmed, it's, you're going to be on your own and you're going to lose. It's not going to work. So that's why we have poems. That's why we have our check boxes that we check. And that's why we monitor you carefully, and that's why we give you breaks. So pulsing is something I originated in 2002, and I've been using it ever since, just based on my background in infectious diseases, looking at the target organisms. This is not HIV/AIDS, which replicates every 30 minutes, but looking at the target organisms, looking at the toxicity involved. People with HIV/AIDS didn't get toxic like this on therapy. They didn't get these, horrible reactive arthritis and headaches and confusion and just uber toxic storms. So we invoked pulsing. It's on my innovative list that's online. 2002. Jemsek and others were responsible for the pulsing concept. I think there are others online right now taking credit for it. Shame on them. But, I'm over it. Thank you.
Really quick, while we're on the topic of pulsing, a question from Germany came in that says, there's a big controversy over here about pulsing and Bartonella. Many people think that you shouldn't pulse with Bartonella. What do you think about that?
No, I think that's fine. Now, actually, as we get into therapy, we do intensify therapy. So in week 2, we have a kill week. So this all ties into our biofilm approach, which we really haven't discussed. But trust me, we go after Bartonella very intensely, but only until the patient has had some immunologic restoration and is very good at detoxification and it is in a nice rhythm. As we get into our latter phases of therapy, we will treat very vigorously. Now remember, as we go forward, we step down therapy and we eventually go to maintenance, and there's Bartonella coverage in the maintenance, so it goes on for quite a while. So I disagree. We've gotten a lot of people better doing what we do and not seeing recrudescent Bartonellosis.
The next question is about college students with Lyme, and what advice do we have for them who are thinking about moving away to college, moving out of their parents' house without their parents' help. So this is a great question. My answer would be, well, it completely depends on where you are in treatment and your level of functioning at the time you're thinking about moving away to college. If you're doing IV therapy, probably not the best idea. As you probably know, you need a support person in place. They need to be with you. You need to change your dressing. So not super recommended if you're doing IV therapy to move away from your support person during that. But if you're, further along in treatment or not treating at all, or maybe on maintenance, and you feel like you can live independently and you feel like you can remember to take your meds and feed yourself, then I say we support that as long as you have a plan in place for if your symptoms return, if you have a relapse, are you going to talk to your professors? Are you going to warn them, this is something that I struggle with, and if I end up needing to go home or move back home with my parents, how can I still continue with my classes, or can I take a leave of absence? So I think planning ahead is huge with this. But again, I think the answer completely depends on where you are with treatment. I know a lot of my patients have moved away to college thinking that they can live independently, and a lot of things like the memory decline, they forget to take their meds. That's a obviously huge problem that's going to delay treatment. Not only if you forget to take your antibiotics, but if you forget to take your stabilization meds. And a lot have had to move back home with their parents. So we don't necessarily, at least I don't, try to rush that decision to get back to school. We really want you to be in the healthiest place possible, not only because you're still sick, but college is a stressor in itself. So classes, studying, just the energy of walking to class, having to, sit up in a chair all day long, listening to your professors, that's just a huge stress on the body. And so we want to minimize that while we're treating. So, in short, I would say depends on where you are with your treatment and your level of functioning.
Right, so a lot of kids take a gap year. A lot of kids are devastated if they can't go to college, but so we have a conversation about that, and of course it's COVID now, so a lot of things are virtual and online, but before COVID, getting into an environment with so much stimulation, oh my gosh, you get your new college student, are you kidding me? It's just overwhelming. We've had a lot of kids come back home and fail and get discouraged, and we've had a lot of new patients who've been through that and found that out. Very tough on a young person, say, I can't go to college, I'm falling behind, so very tough situation overall. So it requires a lot of support, a lot of understanding, a lot of individualization of who this person is, how far away they are, what's their caseload or course load, do they have support? We're happy to write letters for their support so they can have special accommodations of whatever they need, and for the most part it goes pretty well.
So the next question, one of my favorites, I don't think we're going to have time to dive into it too deep today because I think it really deserves a lot longer than a 1 or 2 minute answer, but I wanted Dr. Jemsek just to touch on this for a few seconds, which is how do you determine whether someone is going to do IV or oral therapy?
This is something that we've dealt with for a long time, and I'd really like to give it 10 or 15 minutes on our next live stream or the one to follow, because I'll give you some facts. We're about, we see the sickest patients from all around the country and used to see patients from around the world and hope to do so this year or next year again, because I really enjoy seeing international patients. And we really fight very hard for our patients and try to outline their issues, try to work with other collaborating physicians, if possible, where possible. But in broad terms, about 85% of our patients end up on oral therapy, which is not terribly expensive. The visits aren't that often. And, we have a triage service. We monitor the patients. We do safety labs. And we try to see them every 3 to 4 months until they're finished. But remember, I said it's 12 to 15 months, so they're basically 3 stages of therapy. So IV therapy, broadly defined and indicated, would include deeply seated, profound central nervous system deficiencies, especially in the presence of a history of failed therapies, whether IV or oral in the past. Other criteria would include, and it's all about pharmaceutical presentation, bioavailability with IV drugs. Now, when we do IV therapy in our infusion department, patients are seen a little more often. The IV site is overseen by a trained person, and we monitor the patients very carefully, obviously. We do a sequence of therapy. It's not the same drug month after month every month. We have priorities in sequencing, just like I said earlier on. But it's only about 15%. Now, I'll grant you there's another 5 or 10% that should be on IV therapy that are on the cusp but can't afford it. And that's because insurance doesn't pay a darn thing. And that's on them. They have so much money. They have untold billions in their coffers, and they can't spend it. So it's just a tragedy. It's an American scandal, quite honestly. But on the other hand, I think we have to have a more organized program to assess IV therapy and to prescribe IV therapy. So it's just, if you're a practitioner and you want to do IV therapy with Cephin for 4 months, well, number one, that's not going to work. Number two, you're not doing your patient a service, and it's going to be very expensive for them. So we need to have compelling clinical trials that say, okay, there's a benefit for pulsed IV therapy done in sequence for the reasons the broad reasons I just gave. And we'll talk about this more next time. People think we're an intravenous factory. We're not at all. And but there are some folks that we can say aren't going to get well with oral therapy, no matter how long we try or how hard we try. They're not going to recover maximal benefits.
We have a quick question. We've actually had a few quick questions about Dr. Jemsek's thoughts on men taking testosterone during treatment and how that would affect their Lyme, or if you're on board with them taking that.
I'd rather women take testosterone. So testosterone deficiency in men or women is not a trivial thing, but it does become a second-tier situation for men. With women, if they have no testosterone, we work with women specialists, good at hormonal therapy, creams, things like that. We really believe testosterone is important for brain function, obviously for vitality, mild anabolic properties, given in a dose that doesn't virilize the woman, that is, grow mustache. If you take testosterone therapy as a male, just realize you're inhibiting the the Leydig cells, which produce sperm, and you're going to shrink your testes, and you're not going to be able to reproduce. So if you're under 40 and in a relationship or married and want to have a family, that there are other ways to do it, whether it's Clomid or HCG or what have you, an anastrozole, which is a blocker, a aromatase blocker. So that we need to take that into consideration. So for males who have very, very low testosterone, we'll look at that. But again, if you're giving exogenous testosterone, you're going to suppress the testes, and you're going to have trouble making sperm in the future.
These next two questions I'm not going to dive into because me and Dr. J in November, I believe, did a full hour on how Lyme disease affects relationships meaning with significant others, friends, family, coworkers, bosses. So the questions are, how can I support my caregivers? And my biggest fear is getting into a relationship while I'm still sick. Do you have any advice? So again, we're not going to get into that because we don't have enough time, unfortunately, but please refer back to November's live stream where we did a full hour on advice about relationships while you're sick. And I think we have time for one or two more questions. So the last two will be for Dr. J, which are, we all know testing can be unreliable. What is your opinion on when to ignore many negative blood tests and just treat based on clinical symptoms?
Pretty much all the time. I mean, if you have an unreliable system, we all know what some of the better labs are. Probably 𝗬spot is the best diagnostic tool. But there is one exception that I would say with one of the co-infections. And I'll get to that in a second. But, I mean, if you have had experience with thousands of patients and you have created various concepts and been innovative and had certain results which are reinforcing, or certain mistakes which put you in another path, then, and my colleagues here are experts in patterns. What pattern did the patient have? How did they get sick? When did they get sick? Did they get sick, become ill and incapacitated in a slow way with just kind of taking small bumps down the stairway, or did they fall off a cliff? And what are they dealing with now? Did they lose their job? Did they lose their position for promotion? Did their marriage dissolve? And many, many other impacts of this chronic illness, which pretty much divorces you from the real world in its most severe effect. You can't think, you can't process, you can't communicate. And so we look at patterns, we look at severity of disease, we prioritize how to stabilize. We're very good at sleep management, we're very good at pain management. That's not to say we won't work with sleep doctors, not to say we won't work with pain doctors, but we have to be good. You have to be good in many, many disciplines. You have to understand the endocrine system, the digestive system, the immune system, the nervous system, psychiatric system, GI system. There's so many things. So we look at patterns now because we can't rely on tests. There's no marker like HIV. HIV became fairly easy, in the 90s. After the 90s, we got HIV markers and we could monitor. And then that quickly led to combinations of antiretrovirals which work. And we can actually measure reliably what's the viral load. And I was with Mike Sag playing golf when he announced this, and he said, "Now we got a viral load." I said, "Pop, that's news," because I went to a conference every year of kind of rogue physicians in HIV who, trying to pick up on the science before it really caught fire and got millions or billions of dollars from the government and from pharmaceutical companies. So but HIV/AIDS became relatively easy. We don't have anything comparable with Lyme disease. Remember, we have multiple pathogens. The spirochete is the most complex and evasive organism on the planet, the most genomically advanced organism on the planet. That's why I say we all have it, because once it's in, it's in. And our immune system can handle it unless it gets a lot of, it makes a party and gets a cabal involved, especially Babesia. And especially if you have a rowdy lifestyle, don't take care of yourself, or you're genetically predisposed to have trouble with toxins and illness and so forth and so on. So that gets into methylation, which is a subject that I want to talk about with a future moderator, 𝗧𝗜𝗍𝗘𝗦𝗧𝗔𝗠𝗣𝗦, who's our research person here at JSC, been in with us several years. So that'll be coming up this spring. So yes, it's about patterns. Now there is one test, I'll get to that. Testing is so darn expensive. IGeneX has raised their prices through the roof. Nobody's inexpensive. Guess what? We don't have prevalence data. So where's our data testing 1,000 people with 1 or 2 different labs, and how many people are seropositive? Don't you think that's important? Do you think they're all sick? No. So we need prevalence data. And what we have now is we're so test oriented. I've lectured about this in the past. Treat the patient, not the test. Listen to the patient. None of this happens unless you listen to the patient, spend time with the patient, touch the patient. It's so basic. That's medicine. And what is medicine without patients? Nothing. Okay. What is medicine without a patient? No patients. Okay, what do we do? What do we do? Thumb through our textbooks, every day and talk to each other. What do we learn? Nothing. You don't learn anything unless you talk to the patient. So you learn patterns and you become a doctor. And you have experience and you have expectations of your treatment. And I think that's so important now. It'd be beautiful if we had tests to help us along, and sometimes we do, but we don't have any kind of marker that tells us this patient's better, this patient's worse. And that's a shame. And so that's why it's the same why COVID interrupted the GLA study, the landmark pilot study that they enrolled JSC to be the primary investigator. That would have been wonderful. We were affiliated with University of Missouri, University of California at San Diego, and Columbia, each of whom had specialization in various advanced techniques in molecular genetics, microbiology, cytokine measurements, and so forth. That's by the board because of this damn COVID. But hopefully it'll be revived one day. We need science that we're all looking for something to help us. And but that doesn't mean that you should discard the very important interaction necessary for this complex illness and the understanding and the very thorough attention you give to new subject matter and new findings on examination. There's no substitute.
I want to end just by saying that I believe in Dr. Jemsek's care, his treatment plan. I was an IV patient of his, and I was so sick and debilitated, and seizures and partial paralysis and all. Yeah, it was bad. But he has gotten me so much better, the healthiest I've ever been, probably in 15 years. And so I just truly believe in his treatment, and all the providers here. They provide such great care. And thank you so much for all of your questions today. I know we couldn't get to all of them, but hopefully next month, Dr. J will address them. So please keep sending them. We love your questions. Don't stop. And thank you for watching. I know I really appreciate it. Dr. Jemsek really appreciates it.
Well, we all appreciate you, Jules. And thank you for the kind words. And for those out there, this is my little nutcracker I showed before. It's got a rosary on it to keep all the haters away. Because I know you're out there, you haters. I know you're out there. I know you're out there. Are you finding out how ignorant you are, haters? Anyway, this is my little friend here. It was a gift from a patient. I don't go out and buy these things. Patients bring things by. And I love my patients. Take care. God bless.